All right, I wanted to welcome everyone. My name is Jeffrey Goodman. I'm the Director of Marketing and Development here at the YMCA of Northwest Louisiana. So appreciate everyone being here this morning. First off, I wanted to thank Christy Dixon and Amanda Falon from Community Foundation and Susan Reeks from CADA, who had the idea for us, the YMCA, to host today's discussion. Today's the 7th panel. The YMCA, excuse me, let me just get rid of that. Today's the 7th panel the YMCA has hosted as part of its Shreveport, Bossier, My City, My Community, My Home initiative that we launched in February of last year. We've also published 78 podcasts as part of this initiative, and you can find video of all 78 episodes and the 6 previous panels on the YMCA of Northwest Louisiana's YouTube channel. The purpose of this initiative that I launched in February of last year is to help our community cultivate a healthier self-image and to leverage our position here at the Y as a community center to bring people together like this morning to address some of the challenges we're facing. So a few quick notes about tonight's format, or this morning's format, sorry. We have an hour-long program where you'll hear from the 5 panelists at the table there, as well as a few community leaders who are working hard to build a stronger community for all of us to live in. We expect today to be very informative and full of valuable information. We just ask that when someone's speaking, please be respectful. At the end of the hour, we'll have a Q&A session with the panelists. If you have a question for the panelists, we just ask that you write it on a note card and turn it in to Susan. Susan, if you could raise your hand. And all of you, I believe, Susan, in this correct, everyone should have a note card at their table and pens. Susan and I will quickly review all the questions that have been turned in, and we'll ask as many of those as we possibly can in the final half hour. And then lastly, you'll notice a few tables set up around the perimeter of the gymnasium. These are organizations who would love to speak with you about ways we can all get more involved in helping our community better address addiction and mental health issues. So thank you all for being here. And Christy, if you wouldn't mind saying a few words.
Good morning. Thank you, Jeffrey and the Y, for having us this morning. I'm Christy from Community Foundation, and one of the things that we do is try to assess community needs and problems and then strengthen the community through philanthropy. And a lot of times when we're convening philanthropists, what we find is not only do we need philanthropy to be in the room, but we also need other partners. And so the Crisis Response Coalition that LSU Health Sciences Department helped form, specifically Dr. Patterson and Laura Alderman, really started this conversation, and we're so thrilled that so many partners have come together. Shreveport Police, the Sheriff's Department, the Fire Department, all of our first responders, 911, 988. That is the kind of collaboration that you need to really make change in a community, so I'm thrilled that everybody's here today and that you're here to find out more about crisis response and how we can better serve not only our community members but not overtax the systems that we currently have in place. So thanks so much, and eat lots of breakfast.
And now we'll hear from Bill Rose, who is the Executive Director at CADA.
Good morning. Well, Jeffrey, I think you stole a little bit of my thunder. I did want to start out by thanking Christy and the Community Foundation for sponsoring this breakfast. So there's plenty of food. Help yourself. And also thanks to Jeffrey and the Y for hosting this event. I don't see, is Laura Baxter here? Or Dr. Patterson? No, I think a special shout out needs to go out to those guys for all of the work that they put into making sure that we have some response to crisis issues in Region 7. I think, has it been a week ago, 2 weeks ago, we had, they organized a meeting of all of the heads of community stakeholders. There was a summit that's kind of a precursor for what we're doing today. And I think Susan did have the idea that we needed to talk to the people that's on the front line. So we do have some special panelists here that hopefully can answer any specific questions that you may have. But before I move on, one of the things that we talked about that we brought to the table was a number of peer recovery support specialists that have been working within CADA's programming for at least the past 2 years. And you'll notice that good-looking group of folk at the table on the end, or a group of the peer support specialists that we have. So we're extremely grateful for that group. Again, I do want to thank Susan Reeks and Chris, because they have been on the front line talking to me after the meetings and talking to me about CADA playing a significant role in crisis response. So thank you, Susan. Thank you, Chris. Last thing I want to do is briefly introduce some of our team. Of course, Susan Reeks, who I give a lot of credit to for what we're doing with crisis response, as our Chief Development Officer. We have Susan Garcia, who's our Chief Operations Officer. I don't think Tiffany Hill is here, but she's the Director of Clinical Services. Of course, we have Carrie Vines, the Director of Client Relations and Engagement. I think you have seen Chris, and he's the one that you need to give some kudos, because he helped arrange some of the food, although Christy bought it. Well, there he is. And then, of course, Jennifer Gerald is our peer support supervisor. So thank you all for coming out. I'm going to get out of your way, because I think you all came to hear these guys, not me.
Thank you, Bill. And so I'm going to quickly provide some bio information on the 5 panelists, starting with Chris Fort. Chris Fort's a native of Northwest Louisiana. Chris joined the CADA team in 2017 as a member of the support staff and is now CADA's marketing and development liaison. Chris's passion for fighting the opioid crisis began after losing family and friends and almost his own life to addiction. Chris is one of the instructors for the Shreveport Police Department's Crisis Intervention Training for the Understanding Drugs and Community panel. Chris Boyd. Chris has been sober for 1 year, 8 months, and was a client at the CADA residential program 2 times. Those interactions are what made him want to come work for CADA and eventually become a peer support. During this process, he personally encountered areas of the treatment system that could be improved when it came to the ways law enforcement and hospitals interacted with people suffering from alcoholism, addiction, and mental health. He has a background in psychology, emergency medicine, and mental health. Corporal Dixon. Corporal Matthew Dixon has been on the Shreveport Police Department for 8 years. In his time with SPD, has worked patrol, crime scene investigation, and most importantly, he has been a crisis intervention instructor for 2 years, teaching SPD, SFD, Caddo, Bossier, and multiple other agencies on how to be effective communicators while answering calls for service for our citizens living with mental disorders. Officer Dobbs. Officer Corey Dobbs is a patrol officer with Shreveport Police Department, as well as a trainer for crisis response and intervention, or CRIT. Recently, based on his interest and passion for mental health, he was offered an opportunity, along with Corporal Dixon, to attend CRIT training in Salt Lake City to become a trainer of the CRIT curriculum. Officer Dobbs utilizes the fundamentals of CRIT on a daily basis and is ecstatic at the results he is experiencing. Lastly, Gardner. Glyn is a psychiatric mental health nurse practitioner serving in the Ochsner LSU Health Shreveport emergency room, caring specifically for ER patients in acute mental health crisis. After graduating with his nurse practitioner degree, he began working in the Ochsner LSU Health Shreveport Psychiatry outpatient clinic and Louisiana Behavioral Health inpatient unit. He transitioned from inpatient psychiatry to emergency psychiatry in September of 2021, where he continues to provide compassionate care for patients facing a mental health crisis. So with that, I'd like to jump into the first question. The first question is for Chris Fort, and the question is as follows. Chris, CADA has been named the provider for crisis response services in Region 7. How will having CADA as the provider for crisis response services change the way we address people in crisis from addiction and other mental health issues in our communities?
So I took a lot of time to think about this question, and I will be answering it from the perspective of lived experience. I've already seen the difference of this being implemented in a smaller level. Dixon and Dobbs, I've been fortunate enough to ride along with both of those officers and see them serve with empathy and compassion and de-escalate situations that could have potentially had different results if they weren't the officers that had been trained in crisis response. One was an adolescent. She was hostile at the call. By the time we left the call, the young lady was smiling, laughing, and there was no non-voluntary committals issued. She was able to work it out with the family member. So I got to witness that firsthand of how these situations can be de-escalated and not go non-voluntary, not be committal, and be voluntary on that person's own terms, which helps not add to a trauma response. I'm an 8 on the ACEs study. If you're not familiar with the ACEs study, that's an adverse childhood experience. 10 is the highest score you can get. Both of these gentlemen and Amy have heard my story probably so much they could probably tell it for me. I feel sorry for them, but I come from a long lineage of mental health, co-occurring disorders, dual diagnosis. Both my grandfather, and mother suffered from alcoholism and bipolar 1 and 2. I got all of the above. So back in the 80s, before these services were available, I saw my mother unfortunately mishandled at the time by officers, and that does not happen today. These officers serve with empathy, they serve with compassion, and they truly love our community, and they love what they do. So we are very, very blessed and fortunate to have them, and Amy as a liaison and our leader. I've been beside them for 4 years now. I do teach the substance use disorder with Dobbs now. I was able to start with Sergeant Rachel Alcar, who served as the mental health liaison for the Shreveport Police Department, and I learned so much from Sergeant Alcar. And I'm now learning a lot from Dobbs, and I'm learning a lot from Dixon, and I look forward to learning from everybody in this room. When I was interviewed this morning, the main thing I wanted to drive home is that this is not a CADA thing, this is a community thing. It's gonna take all of us together working as one unit to make this succeed.
Thank you, Chris. And my next question is for, I'll let you decide, but it's for either Corporal Dixon or Officer Dobbs, and the question is as follows. At the Leadership Summit last week, Shreveport Police Chief Wayne Smith said a mental health call can tie them up for hours. How many of these 911 calls are Shreveport Police receiving per month, and how many Shreveport police officers do we currently have on patrol?
I'm going to go ahead and take this one. Thank you to Lieutenant Bowman for crunching numbers late into the night and trying to figure out some more precise data than what we had on hand. Starting back in 2021, from September to December, we had 763 calls dispatched as mental health calls or crisis calls. And then 84 on top of that were changed on the scene by officers to crisis calls. For 2022, for the entire year, we had 2,655 calls initially dispatched as crisis calls. Another 154 on top of that, changed by officers for a total of 2,809. So far this year, as of October 22nd, we've had 2,835 calls, with another 68 changed by the officer, for a total of 2,903. Now, that's just the calls that are dispatched as mental health or crisis calls. On scene, it may look a lot different. We get disorderly calls, welfare concerns. 6,700 calls dispatched this year so far that were coded just as welfare concerns. And half or more of those could have easily been coded as mental health or crisis calls. And one of the problems with that right there is that officers haven't had significant training to recognize some of these mental health conditions or mental illnesses. Or another problem we have is that may not be the primary on that call. If it's a burglary call dealing with mental health, it's still obviously going to get coded as a burglary call. Mental health may have, a huge aspect of that. Right now, as far as specific numbers on patrol, it does vary day to day. On one shift, we may, on a good day, have 40 officers for the entire city. I've seen it go as low as 20 to 25 when we're super short-handed. And for any one of these calls, typically, we're going to have 2 patrol officers respond to each one of these calls, if not more, depending on the circumstances, if it's a weapon involved, if it's highly escalated. So what that's going to look like is we're going to have 2+ officers go to this call and begin to de-escalate and assess the situation. Beyond that, 1 or 2 officers are going to take that consumer to the hospital, most likely, to the emergency department. And then one of those officers is going to have to sit through triage. That could take anywhere from 30 minutes to 90 minutes, depending on the volume at the hospital. So after that, there's report writing and all that, so it does tie somebody up for hours.
Thank you. My next question is for you, Glyn, and the question is, how many mental health cases are currently coming through the ER at Ochsner?
So what we're seeing roughly, somewhere between 325 to 400, depending on the month, is what we're seeing. To give you an idea, if we're looking at 400, the average stay in the ER is going to be anywhere from 3 to 6 hours on those patients. So each month and we've only got an 8-bed unit to take care of psychiatric patients, so it stays pretty much full all day. I was letting these officers know today, I broke the numbers down a little bit between patients that are walking in and patients that are being brought in by SPD or other agencies. And we're getting about a quarter of our psychiatric patients coming in either on an order of protective custody where somebody went to the coroner's office and said, hey, I've got a family member or a friend who's in trouble. Or these guys, officers, are recognizing on the scene that this is a mental health problem and not a criminal problem, and they're bringing the patients to us, which I think kind of goes back to what was being said earlier about how they're getting better at recognizing mental health and not criminality and getting people the help that they need. So I want to give a kudos out to these guys. Thanks, guys.
Thank you. My next question is for one of the 2 officers as well as Glyn, and the question is, would you mind talking about some of the challenges you face in being able to effectively respond to certain crises and situations, and you guys can decide what order you respond in as well.
some issues we have responding are going to be usually be outside people on the call. When you have family members going through a crisis or something of that nature, police pull up and immediately, due to uniform, due to the weapon on our hip, the call's gone from a 5 to a 10 in just a matter of seconds. So that's the issue, is outside of it. Our supervisors have been fantastic since CIT has begun the crisis intervention training, of giving us the time we need and the tools that we need to effectively do our job and do it well for our citizens. Another issue we have is, like I said, the time is because when someone's going through a crisis, a lot of times they're not going to want to go to the hospital immediately. So it's a lot of time of de-escalation, talking to them, understanding, and not just hearing them, but truly listening to the person in their crisis and using that empathy over sympathy for them, because that's what people need at that time. Everybody has something to say. They want to talk, and we are just using active listening skills and getting them the correct resources through CADA, through LSU, through anywhere we could to get them where they need to properly. Yes, sir.
I think probably one of the biggest issues that I have, I kind of, where I'm at, I kind of have a yes or no decision to make with patients as an ER provider. My job is to decide if somebody needs to go into the hospital or whether they need to, they're able to go home safely, and then what needs they have. Do they need rehab? Do they need social work, homeless help? Do they need counseling? Things like that. Where I run into my biggest problem is, I think that I'd have to say it was probably we have a certain part of our mental health population that is homeless. Unfortunately, drugs and alcohol play a big part in that, but it also plays a part in how the ability these guys have of getting shelter. If you think about somebody who's got a mental health issue, who's got a drug problem, often comes into wherever they're staying high or drunk, or they're just not on medicines and they're not able to control their emotions and control their actions, that's not somebody that most of the homeless shelters want in their shelter. They've got women, they've got children, they've got, people that are out on the street for other reasons. So they unfortunately have to prioritize who they can and can't take care of. And that's left a portion of my patients that they have nowhere to go. So of those 300 to 325 to 400 patients that we see a month, depending on the weather outside, 50 or 60 of those could be one of my homeless guys, or a portion of my homeless guys showing up 20 times a month, 15 times a month, trying to get into a hospital because they have no other way to get shelter or food or anything like that. And that's somewhere where I think that maybe as a community we could potentially do some good. So that's why I brought that one up. So thanks.
Thank you. My next question is for one of the two police officers in Glyn again, and it's just tell me a story about a time when you felt as though you did not have the proper tools to respond to the situation you were facing.
I'm not going to speak specifically on that, but coming into the department less than 2 years ago, crisis intervention training was already being implemented. Since then, it started to gain some traction, but we always only had limited solutions in these situations. We have, an RPC, which is a request for protective custody, where we take someone to the hospital. They get evaluated and ultimately probably released back, either onto the streets or to their families. And we're seeing a revolving door effect with that. People are, we're having repeat consumers. One of the good things is that after we use this crisis intervention training and contact these people who are in crisis, they start to see us more as humans and not as police officers when we show up on scene. So it's an immediate de-escalation effect. So they're more interested in talking to us. They'll pick us out of a crowd of police officers and be like, I'm talking to that guy. So it's coming around full circle now. We are actually starting to gain some traction with CADA getting involved now, and the bridge, where we're starting to kind of centralize resources. And that's one of the things that I think CADA is going to be able to help us do as patrol officers. We don't carry around a Rolodex of all these resources on us, and we don't always think on the scene of what's going to be the most appropriate course of action. We're trying to, get through these calls, get them somewhere quick to, remove them from the situation. But going forward, I think this is really going to help us to kind of centralize things, get people the resources that they need, the follow-up that they need, give them a support system, maybe somebody to help, work their case, make their medications and treatment more accessible. And in turn, that's going to bring these numbers down, and it's going to humanize us all a little bit more.
I guess one of the stories that I kind of have to be a little careful how I tell my stories, HIPAA and all that. But one of the challenges that I find that we face in the ER is with children. Across the state, if I've got a child who's in crisis, and to give you guys a little background, children don't generally have schizophrenia and bipolar. They can, but it's not generally what their problem is. It's those big high ACEs score. It's trauma. It's PTSD symptoms. It's lack of an ability to regulate your emotions because you haven't had a good role model and you don't have coping skills as a 10-year-old or a 12-year-old. When I get somebody in like that, one, medicines don't fix that problem. That problem is fixed by counseling, lots of it, and for a long period of time. I have a lack of beds across the state to send people to, which means that those kids end up spending 2 or 3 days in my pediatric department or in my ER because I can't get them over to peds because peds is full. And they're sitting in an open bay ER listening to the 45-year-old schizophrenic male who's off his meds and screaming and hollering, or the person that these guys have to bring in, maybe with some drug problems and not happy about being there. And I've got a 12-year-old with nothing to separate that person from all of that but a curtain. And then even if I can not have to send that person in, if I'm looking to send them to a group home or something like that, those have waiting lists. I know the Methodist Children over in Ruston has a waiting list of generally somewhere in the neighborhood of 45 days. So taking a child who's in the CPS system, who's been through 3 or 4 foster homes, who, the foster parents have, I can't do this anymore, this kid's causing me too much problems, and they have nowhere to go. They're stuck in a horrible situation. And I haven't, we struggle. I've got one of my social workers here, and she's an angel helping me get people where they need to be. So that's where I see another problem that we can maybe fix. Thanks, Beth.
Thank you. Okay, my next question is for Chris Boyd and one of the 2 officers, and the question is, talk about how the CADA peer specialists will work with first responders such as Shreveport Police and Caddo Parish Sheriff deputies to intervene and offer an alternative to local emergency rooms or jail.
When I first heard about this program, I was thrilled to try to be a part of it. It's a pretty common saying in the addiction community that the opposite of addiction is connection. And we have just a whole lot of people here who are willing to collaborate and bring together resources to try to make life better for people. And that is inspiring to me. It's been they've listed several of the challenges that we face already, and that there can be people can slip through the gaps. Even if people are hospitalized, whenever they're released, they're released. I mean, they may be given some information, some phone numbers, but we're really hoping to bring a more human element into this. Hey, let me help you get you where you need to go. And even on the front end, doing peer support, we do screenings for people for substance abuse treatment, but also working in admissions. We get phone calls from people who say, I'm in trouble. And, it's like, well, we do the screening. It's going to get reviewed. We'll call you tomorrow, let you know if you can come in. And it's not uncommon to hear something like, I can't stay here. I need somewhere to go. Because in that situation, and I'm sure that the officers haven't encountered this, it's, when do we intervene? Do we wait until a crime is already committed? And then that's when their mental health gets addressed. So I was really excited about this, to try to have a place for collaboration. There are so many resources available, that are disjointed. Really looking forward to bringing that together.
Working with CADA has been just an absolute godsend to us. I know that Chris Ford, after a while, started seeing my name and Corey's name pop up on his phone to the point where he just had to take a breath before he answered it. I had just met Chris Boyd a few days ago, and after meeting him and getting his phone number, realizing what he does for him, he got 3 phone calls from me within an hour, because that was every single call I was going to after that. And I was making the joke with him, you done messed up, give me your number, man. But working with CADA and all that to give alternates to jail or the hospital, it's giving people options. People in crisis are usually at this point not used to having options. They're not used to having that sense of control, and that's what it is. They are in control of their crisis. We are just facilitating them and helping them get in where they need. So with CADA opening up their stabilization center, we are able to give people, take the fear away from them of jail or anything, or having their freedoms taken away through guided imagery, through transparency. So knowing what the steps are after this, with our site visits that we do during the CIT training, gives our officers the ability to tell people, okay, after this step, we are going to go here, we are going to go here, and we're going to walk with you the entire time. That way that they see us more as human beings instead of these robotic beings with guns on their hips, that we're humans too. We have emotions. We get scared, we get nervous, and I'll be the first one to tell someone on a scene, man, I'm scared right now. It just shows people that we are not all what you see on the news and the horror stories that you hear. So working with CADA has just, like I said, it's just been a godsend, because people are starting to approach us more and just straight tell us, I need help. And we say, okay, come on, let's get you that help you need. And it stops the, as he said, the revolving door, and we are more friends of the community versus something that people fear.
Thank you. And then my final question for the 5 panelists is, and this is for Chris Fort, one of the 2 officers, and Glyn. The question is, how can we come together as a region to build a network of resources, and how can an organization become a part of this network you are building?
I'll go first. I think we're almost already there. I look around this room and I see colleagues, I see coworkers already in this room that I don't even work with in the same facility. Andrew, LACG, Yolanda, Hershey, Allison, Volunteers for Youth Justice. I see Jennifer Burris back there. We do stuff for her all the time with the Louisiana Addiction Research Center. We work real closely with them. The Bridge. I already have so many people that I can contact when our services just don't match the criteria. We don't handle dementia. We don't handle Alzheimer's, but I have a resource that I can give that person. We saw that in a call. Somebody was experiencing sundowners. I don't know anything about sundowners, but I do know who does, and I can pick up the phone and call that person and do a warm handoff, and that's what this is all about. If we don't know what service to provide, I can offer that warm handoff to the agency that it best fits.
On SPD's side, somebody wanting to get into this, we're hiring. So, always a possibility.
We'll have applications at the door.
Yes, it's a recruiting event. No, it's very, very easy coming together as a region. It's just openness and the willing to talk with people and not be scared to give them a call. My phone rings at 2, 3 o'clock in the morning from officers, from other people saying, I need your help. What do we do here? What do we do here? And my wife absolutely hates it, but the call get answered, the person gets the help they need. So it's really, as long as we can all continue to work as a team and continue the road that we're going down, there's no doubt in my mind that this is going to be extremely successful and not only great for us, but for the citizens, and cut down on the negative interactions that Shreveport police has with their citizens living with a mental disorder. And as far as getting on the board with us, we have Lieutenant Amy Bone back there. We have Lieutenant Sanchez, Diane Sanchez back there. Give any of us a call and we can direct you to the correct person at the Shreveport Police Department to help assist you with getting the correct hands to shake, so to speak.
Thank you. And Glyn, just before you go, Chris, can you say something about the QR code as well?
On the table, if you would like to be added to our resource list, just scan the QR code. We also have business cards that have our full brochure that tells you all the information you need to know. One place I failed to mention, I would like to mention Caddo Sheriff's Department too. They've come on board full force. Roppolo likes to call me at all times, and I enjoy the phone calls and the conversations, and we've seen several cases get resolved. So thank you to the Caddo Parish Sheriff's Office as well.
For those of y'all that didn't hear, that's Captain John May in the back. He's been a big part going forward with this. I appreciate him very much.
All right, I'll finish off, hopefully nice and quick, for the first time all day, sorry. So to me, from my perspective, the easiest ways we can maybe make a difference as a community is let's try to figure out a way to remove some barriers for housing. How can I get somebody who doesn't have an ID card into a shelter? For those of you that don't know, that's a requirement to be in a shelter. You have to have an ID card. Shelters need to be able to run your ID to find out if you're a sex offender. They can't put you in a room next to women and kids if you're a sex offender. So if you don't have an ID, you get to sleep under the stars tonight in 32-degree weather. It's a bad day. And of course, rehab beds are always at a premium. So anybody wants to open a rehab, I'd give CADA some competition. I won't be mad at you, CADA might, but I won't. So that's pretty much it for me.
Thank you. And so as I mentioned thanks all of you. So as I mentioned at the beginning, we'll now hear a few stories from some partner organizations, and then at the very end, we'll come back to the panelists with questions that were turned in from you, the audience. And so again, if you have any questions for the 5 panelists, please write them down and hand them to Susan. And so we'll start with Laura from the Bridge.
Good morning, everybody. My name is Laura Gauthier, and I'm the program director at the Bridge Alzheimer's and Dementia Resource Center. We're a local nonprofit that helps families diagnosed with Alzheimer's and the other types of dementias. When Susan reached out to me about this particular having a story, I immediately had one pop into my head. So I've been with the Bridge for about 1.5 years, so I'm still learning as I am with my families. And so I get a call from a very concerned wife. Long story short, her husband woke up, had no idea who she was, and he was visibly and just scared out of his mind that this strange person was in his house. And his wife had no other option to do but to call the police. And Corporal Dixon happened to be the officer on call, and he had one of our rat cards because we are one of the trainers for the crisis response for the police officers. And he was able to de-escalate that situation. And when that gentleman saw the police officers, he immediately was at peace because he was a veteran. And so they took him to the VA hospital. Unfortunately, he was not able to stay there. But the story has positives and negatives because there is that collaboration with the police officers, and they were able to give them the good and the right information for that wife to give us a call. But unfortunately, that person still had to go to the hospital. If the stabilization center had been open, then they could have taken him there to de-escalate the situation further. He may have had to still go to the hospital, but he would have been in a better place mentally, and he would have been able to get not necessarily better treatment, but different treatment in the long run. So we are very proud to be part of this collaboration and this coalition with everyone. So thank you.
Thank you, Laura. Next, we'll hear from a representative from the Philadelphia Center.
I'm Hershey Krippendorf, and I'm the Director of Development at the Philadelphia Center. I also oversee our harm reduction program. That is a syringe service program where people who use drugs can come and get safe injection supplies and sterile syringes. They also have access to Narcan and fentanyl test strips. The crisis call that I'm going to tell you all about is very short and simple and goes along the ways with what the officers are saying. Is that people in crisis, they know what they need to do. They know that they're doing something wrong. And I had a call, and this young lady was driving down the streets and started to tweak. And I don't know if y'all know what tweaking means. That means that you've gotten to that point of using so much drugs, you're like paranoids. And so the phone call goes to where I'm just talking to her and just trying to get her to calm down, pull on the side of the road, and just get outside and take a breath and see what's going on with her. She had reached a point in her life where she had gotten to this, where she's out of control. And so she just needed somebody to talk to about, hey, what's going on with you? What can I help you with? So, just getting to see that people are people, regardless of what their situation is. And this is a great thing. Chris and I go way back, and I'm so excited to be a part of this in the Philadelphia. So, and thank you, officers, for what you guys are doing. We appreciate it. So, thank you.
Thank you. Next, we'll hear from a representative from Goodwill.
Good morning, and thank you for allowing me to speak about the crises that we have within our reentry program. My name is Pat Williams. I work for Goodwill. I am the Regional Reentry Manager who manages contracts with Department of Correction. We serve parishes Caddo, Bossier, Rapides, and Ouachita. Because of the mental health crisis that we have currently in the state prisons, let me go back and give you a little historical perspective. Around 2013, maybe a year or two before that, the state began shutting down our mental health hospitals. Primarily, Central Louisiana State Hospital was one of the prime hospitals in Central Louisiana, which began the trend that more mental health cases were now, instead of having treatment, they were now going into the system. There was a study done by Louisiana Health Center in New Orleans, which did a brief study about mental health in our prison systems. And it said about a third of the 31,000 who are incarcerated have mental health diagnoses. Another 43% had one instance or more of taking psychotropic medications. 4 in 10 Louisiana people who are incarcerated have mental health. 2 in 10 have serious mental health. Out of those 2 in 10, it makes me sad because I have to work with these individuals so often. My team and I have been identified as having schizophrenia. So when these individuals come out and they meet with Goodwill, they meet with Easter Seals, the vast majority have significant mental health issues. There's a new acronym called PICS, Post-Incarcerated Syndrome, similar to PTSD. So I'll give you a quick story of what that looks like. We had a gentleman who was in and out of prison since he was a young man, maybe 9. He came out after multiple stints. After doing maybe 10 years, he went to the family home that he thought that family members were taking care of. The home was dilapidated. He couldn't live in it, holes in the roof, the floors, and rodents. He calls his parole officer, who in turn calls me, because he's now suicidal. Because he can't function within the home. He doesn't understand why family didn't take care of it. She calls me. You have our Apple phones that we can now have multiple people on. Got him the help he needed, had someone en route to get him to a new home, and then I believe he went to CADA. Without this response team, crisis response team, people get lost, and they end up being homeless. And as was previously said, the shelters can't accommodate them. And I could stand up here and I could talk stories all day because they happen almost every day. And without the behavioral health services and the CADA and their 3.1, their housing that transfers into sober living, we couldn't do this. So thank you.
Thank you. Next, we'll hear from Andrew Ameen.
You got a close seat.
Hey everybody, my name is Andrew Ameen. I am the 988 project manager for the Louisiana Association on Compulsive Gambling. And first, thank you all for inviting me up here, Bill, Susan, YMCA, Christy. But when I first got asked to do this and what it was going to be, my first thought was, well, that's going to be really hard to pick out one crisis call from the 14,000 that we've taken over the last 17 months at our call center for the 988 Lifeline. But one came to mind that I took covering the helpline one day, and it was a problem gambler. And it was this guy called in. We do helpline, problem gambling helplines as well, but this guy called in on the 988 Lifeline. And he was at work, and he had just dropped somebody. He was a driver. He was at work, and he was calling the Lifeline because he was suicidal. And at the time, we didn't have anyone else to call. There was no one to call. We didn't have a mobile crisis team. So we tried to de-escalate the situation. We can't de-escalate it. We end up having to send 911. And so 911 ended up going on, they had to go several places to try and find him. And what ended up happening was the police showed up where he worked. They waited for him to show back up. When he got there, the police met with him. He denied everything. He denied saying he was suicidal. He denied having these thoughts. Well, so the police left. He ended up losing his job because the police showed up for him. And he called back a little while later to call me a whole bunch of names. And so this is not one of the success stories from the 988 Lifeline that I'm telling you today. I think if we had something, when this goes into play, when we have somewhere like CADA, that would be a much more appropriate call for something like CADA. This guy he didn't have a gun to his head. He wasn't actively taking all of these pills, but he was having thoughts of suicide and he wanted to talk to somebody. So being able to say, what if I have a peer support specialist come out and talk to you? Or what about this place on Crockett Street where you can just walk into and somebody that's been in that situation before can talk to you about this? That's going to be extremely powerful for us. It's going to be an extremely powerful tool for us at the 988 Lifeline, and we're extremely excited for y'all's collaboration and to be able to have that warm transfer to CADA and to that mobile crisis and to that crisis care center to be able to send people to. So we're excited. Thank you all again for having me up here.
Thank you, Andrew. And lastly, we'll hear from Deputy Roppolo.
Good morning, everyone. My name is Deputy Roppolo. I work with the Caddo Parish Sheriff's Office. I've been on patrol for approximately 5.5 years now. Recently went through the training with Dixon and Dobbs, and Miss Amy and Chris came in there teaching as well. Sold me 100%. I have a military experience. I have lived-in experience with siblings who live with autism, one who lives with substance abuse. Really hit home for me. Immediately following going through the class, Mr. Dixon here can attest to it. I called him quite a bit, picking his brains on calls, because it instantly seemed like I was going to this. And I saw results immediately, within 2 to 3 days of going to this class, because not everybody in a crisis, like they said, needs to go to jail, needs to go to the hospital. They need that place. I had one in particular story that stands out really strong that Mr. Chris Fort and Miss Jennifer over there helped me with. Lady was having a crisis, was in the middle of the street when I arrived on scene. Like Mr. Dixon said earlier, when they see a patrol car, somebody in uniform with a weapon on their side and all this, escalates it automatically. She does not like the law enforcement and does not like men. After talking to her a few minutes, realized the crisis is between her and her spouse. Using guided imagery and tools that I was taught in this class, I was able to get her comfortable enough to speak with me and willing to speak with Mr. Chris Fort over the phone. Someone who doesn't like the police, doesn't like men, willingly got into my back seat because she felt comfortable and talked to another man over the phone, who he in result reached out to one of his colleagues, Miss Jennifer. And long story short, she hadn't committed a crime. She wasn't a danger to herself. She wasn't a danger to others. She was not gravely disabled. She did not need to go to the hospital, but she was still having a crisis, and it's still important. Prior to this, you're next, sorry. Sure. He's been my Rolodex. Like Officer Dobbs said earlier, we don't carry around a Rolodex with a lot of this, but meeting Chris Fort, I know, like he was saying, a warm handoff. If it doesn't fit our criterias, if he's not the answer, he's gotten it for me. And it is a true team effort, because Officer Dobbs and myself also worked a call together. I was flagged down. It was actually, he was dispatched. We stayed on scene in coalition with each other in a team and saw it out with an adolescent as well. So it's a very good teamwork and cohesion, and props to them, because they ended up getting her the resources she needed and got her out of a situation that could have been a lot worse.
Thank you. So we'll now shift the program and ask some questions that have been handed in from people in attendance. And just a reminder, if any of you listening today have questions for the panelists and would like us to consider asking those in the next half hour, you should have note cards on your table. And if you do, just write a question down and find Susan. So the first question is, it's actually not for the panelists, it's for Caddo Sheriff's Office Captain John May and Fire Department Captain Pam Mackey. I believe both are in attendance. And maybe, I'm gonna ask the question, maybe you guys could come to the podium and respond. The question is, how has CIT training impacted community members in crisis, and what agencies have received CIT training?
Hello, I'm Pam Mackey with the Shreveport Fire Department. CIT, we have began to teach several different agencies in the region. We started off with Shreveport Fire and Shreveport Police, and that quickly grew. We started encompassing Bossier City Police Department. We've had some Bossier City Fire Department dispatchers. We've had some Ochners, LSU security guards take our class. We've had Greenwood Police Department, and we've had a host of other agencies contact us about wanting to take our 40-hour CIT class. EMS agencies, fire departments. It's very instrumental when we're communicating with people, and it gives us the insight that CIT gives us, provides us a way to communicate with just complete strangers. It teaches active listening skills. We're able to get a little bit broader insight on different behavioral disorders, intellectual disorders, and provides us just a host of information as far as, they've talked this morning about different agencies that we can contact and just resources. Chris is exceptional, as everybody has already said this morning. But, the fire department, we actually respond to a lot of the mental health calls that the police department does, because we have to, a lot of times, rule out a medical emergency. And a lot of the calls that we go on are actually mental health calls, but they may be difficulty breathing or chest pain, and then we get there and it's something totally different. They're hearing voices, and so we're able to de-escalate situations, and it's just very productive. And whenever I first took the class a couple of years ago, I was hooked. I've always had a passion for mental health, and it's just near and dear to my heart, and just pushing it forward. And I've been an instructor for 2 years, and we've trained countless people in our region. And so we're looking forward to the coalition and just the gathering of different resources to better provide services for the citizens.
Good morning. I'd like to take just a minute to thank everybody with the Crisis Coalition for what you're doing here. I've been doing this 31 years, and when I first started up until recently, I always felt like we were alone in our responses. Now with your group and getting involved with it, I see we have other alternatives. So many times I've been on calls that were mental health calls. That's what they boil down to majority of the time. It's more prevalent now, where they resulted in use of force incidents. My goal with it is to reduce our agency's exposure with use of force incidents, not only for the agency, but also for the public. I've seen it go everywhere from hands on the subject to less lethal options, canines, all the way to lethal force over basically a mental health call. And you sit back and you play those incidents over and over and over. What could we have done different? Now, with this training, with your help, and with CADA rolling out, it's not only going to be good for us, it's good for the individual and good for everybody else, bringing everyone together. And I thank each and every one of you for it. I especially want to thank Christy and the Community Foundation for believing in us and helping us with our training. She's a big part of it. With our training, we were late to the party. We went in kicking and screaming from Lieutenant Amy Bowman. She brought it to the sheriff's office and quickly learned that we were behind times and we need to get caught up. We've always had a big emphasis on it in our corrections division with those that are incarcerated, but not so much on patrol. And I'm glad to see it changing with people like Josh and some of the other deputies that have been through it. We've only had 3 classes, and it's hard because of our staffing issues to pull people off the street and send them through to the training, because it is 40 hours, but we're making that sacrifice. And so our response times will be slower, but we're going to get the training. We're going to get it one way or the other. And with that, I'm already seeing it on the calls I go to with the deputies. I've yet to go through it myself. It's just hard for me to get in that 40-hour class, but I've got to, because I watch how, I call them all rookies, but watch the rookies, the 20-year deputies, handle these calls with the folks and de-escalate it. I desperately need that. So I'm proud of the work they've done. I'm proud of partnering with the fire department, police department, and encouraging all the other agencies in our region to participate in it as well. It's something I don't want to see stop. In fact, they often tell me we can't do this many classes, but I just want to keep it going to get everybody involved with it. But thank you all.
Thank you. The next question is for the 5 panelists, and the question is, and you can decide who takes it or in what order, what happens after people receive care and services at the Crisis Receiving Center?
I guess I'll take that. So that's where our peer support, our Chief Operating Officer, Carrie Vines, and Jennifer, the one difference with peer support specialists is they're allowed to stick with the client for up to 4 years. So they have that active connection with somebody for up to 4 years. So they have that first phone call if they see a relapse or a mental illness crisis heading their way. And people know, they know when they're headed for failure, they know when they're headed for relapse, they know when their mental health is not right. And having that person to be their voice, which they'll be able to be for up to 4 years, will definitely help that deficit.
So what happens when they come to the Crisis Receiving Center? What type of, and they get a screening, what happens between that time and the time they leave?
The peer immediately sticks with that person, follows through no matter what, whether they come through our program, they go to Brentwood because the mental health needs to be handled first. Typically, that's what our peers have to do. They do a basic screening form that's followed through by SAMHSA's criteria. They ask a panel of questions. It then goes through a clinical director. The clinical director then directs them of where to go next. So if their primary diagnosis is schizophrenia, then unfortunately we can't treat them yet. We're going to have to get the medications right, so they'll have to go through Ochsner's, through Oceans, through Brentwood, through another agency to get on the proper medications for the schizophrenia before the addiction can be handled. But the peer will stick with them. It's logged in an Excel spreadsheet, and they follow through and keep up with the client as long as it takes.
And one of our mottos is, calm, connect, and collaborate. We want to work with these people to find what they want their outcome to look like. Because they can be so much more successful whenever they feel involved, like they're part of it and not just being passed around. So we're hoping to collaborate with these people. We're going to follow up with them instead of, we're making schedules of follow-up calls, check on them, so they're not just out in the wind without support.
Thank you. The next question, Bill, I think this is for you, Bill Rose, is how much money has CADA received from the state of Louisiana for crisis response services? Is Bill in here? I'll come back to it. You want me to come back? You want to answer it, or you want me to come back to it?
Nothing. So there is no funding. I'm glad to get this opportunity. CADA has received no startup funds, and this programming is funded by Medicaid, and so we have to get it up and running with no startup funds and have the staff in place before we can even start billing Medicaid. We're in the process of getting our license right now. I believe it's been submitted to the fire marshal, and so once that license is approved, we can be up and running. But we are putting an enormous amount of resources toward this in time and effort, and we're reaching out to you in this room to come there with us, because one of the things that happens after they get addressed and screened, in some cases stabilized, many times they're not going to go to treatment. Sometimes they're just going to have us look at our resource list, these relationships we're building with you, and we're going to call you and let you do what you do best. And so that's why this is so important that we all come together. It's not about money. We're not getting any money right now. So just wanted to let everybody know that. Thank you.
My next question is for the 5 panelists. It is, how has CIT, crisis intervention training, changed your approach to mental health calls, and how has the public responded to this training? And I know we've touched on that a little bit. Is there anything that any of you would like to add to that?
Yes, sir. The CIT training has been wonderful for the police department and the first responder side of it. Excuse me. We, as police officers and first responders, we teach certain parts of the class to people, mainly the de-escalation portion of it, but we are also able to bring in subject matter experts, Chris Ford, Miss Laura, and bring people in who actually do this every single day for a living, so you don't have just police officers reading to other police officers off of a PowerPoint. We have people with lived experience, we have people with true knowledge of it that gives everybody a great idea of how this all works. And when the public is seeing the officers with the knowledge that they have and the compassion and the care, it really takes so many walls down, and it is able to open up a lot of communication and a lot of sense of safety within our community when the police arrive, which is a fantastic thing to see somebody come up to you and say, I think a few days ago I was on a call for one thing and it turned into a mental health call because they came to me and said, I need help. Let's get you help. And that's whenever I started to blow Chris and Chris's phone up, and it just goes from there.
As I see the CIT and CRIT training gaining traction, one thing that I've noticed is that even though the officer on the call may be fully trained in CRIT and utilizing it flawlessly, having other officers responding to that call as backup, recognizing what that primary officer is doing, and then standing back and letting that officer work and being patient and all that, is making a big difference in how we respond to these calls. Supervisors being trained in this so they recognize what we're doing and why we're doing it and why it's taking 2 hours on this call is helping us to get these people to the resources that they need. And even though we may not get the ideal outcome on the first interaction with some of these consumers, in the future they're going to recognize us. We may be able to talk them a little bit more toward the resources that they need for a long-term goal. So CIT, it's working through everybody, through the officers, through the supervisors, through our entire chain of command, through you guys. You're seeing it, the perception's changing. You're wanting to be involved, and I really appreciate that. It's overwhelming.
One thing I like to cover, and the portion I get to teach with Dobbs now, and I like to drive it home because of the lived experience factor. That's the side I bring to the module, is my own personal struggles with my own co-occurring disorder, and that's being able to tell the difference. And I try to drive it home with the officers, so when they do respond to a certain call, they are able to look at the narrative and the context of the voices. Because until they get into the narrative and the context, a mania episode, a psychotic break can look like a mess psychosis. It's not until you get into the actual narrative that you can tell a difference, whether it's a bipolar 1 episode, a psychotic episode, or it's a methamphetamine episode. So them having those just simple tools to be like, well, maybe it's not drugs this time. Maybe they're not taking their mental health medications, and we need to find them help to get their mental health medications, because sometimes we're released and we don't have access to those drugs, and we don't know how to get access to those drugs. So if we have those tools to give these clients, then it lightens the load on our emergency room and our officers.
And another thing that was brought up, and when it comes to CIT, we don't deal with necessarily just the public itself and their crisis. Police officers are human beings. We have feelings, we have emotions. We have our own crises that we deal with. We take in trauma at exponential rates every single day that we are at work. We are dealing with trauma. We are teaching ourselves that it's okay to not be okay, and it's okay to go get help. If we can't take care of ourselves mentally, we cannot serve the public helpfully. So, thank you. So we truly believe, and Lieutenant Bowman has helped us out so much with it, with getting us counseling if we need it at the drop of a hat, free of charge for us, just for us to be able to let things out, to unload our traumas. That way we can be more helpful to the public. And I know fire department they've gone in suit with it as well, and it's just really helped, because you can really see officers connecting with somebody on a call, because what they're going through, officers have gone through similar things, and you have that level where you can just see in their eyes, I know how to help you. And it's so exciting to watch somebody do that, because we're dealing with our own mental issues as well.
Glyn, do you have anything to add?
I guess the only thing that I would add is being kind of the end user in this. I noticed that there's a big difference between Shreveport and some of the other agencies as far as recognizing mental health crisis and getting them to the ER to get taken care of, as opposed to finding out later that I've got somebody in jail who's coming to me because they're still psychotic after a week or whatever, and then we're trying to fix that problem while they're incarcerated, which, for those of you guys that don't know, once you're incarcerated, if you're still incarcerated, you're not going to a psychiatric facility. You're getting treated with medicines at the ER, and you're getting sent back to jail in that situation to hopefully get treatment there, which is not ideal at all. So Shreveport has done wonders with that, and I'm hoping that everybody else catches up. As you said, kind of behind the times. Come on, get on board, because it's doing great.
Thank you. So my next question's for the panelists, and there are 2 questions on this page. I'll start with the first one. And we're down to the final 10 minutes, everyone, so just to give you a sense of time. The first question is there a nonprofit available now to take care of children like the ones that Glyn spoke about?
There is an application process that has been opened up for a juvenile provider. Just get with somebody after this to find out that information. So hopefully it's coming, it's needed.
Definitely needed.
And the next question on this page was, what type of personnel will be on the mobile crisis team, and how many?
Type of personnel, peer supports are people who have had personal experience with recovery from addiction, who've been able to maintain sobriety for a significant period of time. And that in it of itself breaks down a lot of barriers for people to know that you've been through something that they're going through. Anyone who wants to, I think. We need some. Casey, I think.
Okay. And then the final question that I have is, with respect to childhood trauma and youth violence, are fire and police agencies looking at early intervention strategies?
As far as strategies go, I can speak for the Shreveport Police Department side, is understanding ACEs, understanding adverse childhood experiences, and understanding what happens to a child when they are not given the proper love, care, and support in the home. We can intervene early because we are seen sometimes as a parental figure in someone's life, as a positive role model in somebody's life, that later on you have your SROs at school that you can see, you have your children at school who are, the quote-unquote troublemakers who are just misunderstood, but the SRO is that one person that they connect with because they give them tough love, they give them compassion, they give them care. So we can help the children by just being that role in their life and understanding what's going on at the home. We can try to soften the blow a little bit on our end. That way, hopefully, and later on in life, we run to you, it's because we're both at lunch together and not on something terrible.
Pat, I'm going to piggyback a little bit on that. So
Lieutenant, just introduce yourself if you
I'm
could.
sorry. I'm Lieutenant Amy Bowman. I've been with SPD for 28 years, and I'm the Behavioral Health Liaison. We worked with the DA's office and Caddo Parish Schools. We do have a program now called Handle with Love. It's a notification system for early intervention. So when our officers or the fire department and Caddo, I think, is on this program as well, if we're out on the scene and we see a child that might be involved in a traumatic incident, whether it be a domestic situation, a fire, we take that child's information, the school that they attend, we put it on a sheet, we send it through our communications division, and that goes directly to Caddo Parish school system so that they can start to look for early intervention means, if a child's being withdrawn, if they're acting out. I think the earlier that we recognize that a child's been involved in trauma, the quicker that we can try to get that child the best response going forward so that they're successful.
So I think that wraps up our program. Just one last thing, and then I'm going to let Christy have final words. Just reminding everyone, let's first give a round of applause, please, to our panelists.
Hey.
And just want to remind everyone that we have organizations with tables set up around the perimeter of the gym who would love to speak with you afterwards. So if you have any questions at all or would like to get more involved in everything you've heard, please stick around and feel free to visit the tables around the perimeter of the gym. Thank you all for making the time today to be here. We will be reposting a video of the entire session. It'll probably go up in the next week or so on the WISE YouTube channel, and that's something you can share to people who are not able to come. You can cut pieces of it, use it any way you'd like, as you see fit, for it to be as effective as possible. And then that's all I've got, Christy. So thank you all for being here. Appreciate it.
So I was going to ask a favor in exchange for breakfast. I want everybody to leave here and tell, I was going to say 5, but really you should tell 10 people, give them a summary of what you heard today, and tell them where they can find additional resources about it. Because for systems like this to work, 911 didn't get invented and then everybody knew to call it. It takes a whole community to talk about the great resources that we have and to let everyone know that they're available. Second, I wanted to say, Bill took this on for CADA without hesitation, and it's hard to be the guinea pig, and he did it with no hesitation and no fear. So the best part of my job is that I get to work with people like him and all of y'all every day and hear the great work that you're doing. So huge round of applause for CADA and the panelists. And really, one of the easiest ways that you can share the information is to pass on the video and the clips from today. And then if you do want to know a little bit more about childhood trauma, we're actually having an event at Robinson Film Center next Tuesday at 5:30 where a professor from Tulane is driving up and joining us. He did this really fascinating study on what trauma does to the early developing brain when a little girl who was not even speaking yet because she was 8 or 9 months old, witnessed her mother being murdered. And he treated her and is going to talk about that treatment. So if you want to know more about what trauma does to early brain development, that's next week, Tuesday, 5:30, cfnla.org. You can sign up to come. Just RSVP for a spot. It's free. So, and the Y is amazing. And thank you. And thank you to all the ladies and gentlemen who allowed us to interrupt their exercise class.